In this week's video lectures, we're going to start by looking at triage. We'll talk about what triage is, when do we use it, why is it important, and most importantly, how to do it. Let's get started. So first off, a definition. Triage can be defined as the preliminary assessment of patients or casualties in order to determine the urgency of their need for treatment and the nature of treatment required. In other words, an initial assessment to figure out who needs treatment and how much treatment they need. So depending on the situation, we'll use that information differently. In the normal day-to-day environment, we'll use a triage system like CTAS to figure out how many resources this one patient may need. Do they need to go to resus with a lot of resources, or is somewhere like Fast Track or an observation bed more appropriate? We'll do another video on CTAS later. In a mass casualty situation where you have more patients than you do responders or resources, then triage will be used to figure out which patients get the resources first and who has to wait. There are loads of different types of triage systems for MCIs, but by far the most common is the START triage method. START stands for Simple Triage and Rapid Treatment and originated in the 1980s in California. The system breaks patients up into 4 categories: black, red, yellow, and green, which correspond to the severity of their injury: deceased, immediate, delayed treatment, or minor. They measure these patients on 3 parameters: respirations, perfusion, and mental status, so RPM. Let's walk through the START flow chart. Quickly and see how we can use it in the field. So at the start of the MCI, whoever is organizing the triage will typically direct all the walking wounded, that's the people who are physically walking around, and direct them to one separate area. These people will automatically be color-coded green. Then we'll head to the incident and find the first patient. We'll first assess their respirations. If needed, we can quickly open the airway with a jaw thrust and some OPAs/MPAs. If the patient requires some kind of airway adjunct or positioning, or they're breathing greater than 30 beats per minute, we'll tag them as red and move on to the next one. If they aren't breathing at all, even with some basic airway maneuvers, then we'll tag them black, which means they're deceased. So if the patient's breathing less than 30, we'll move on to perfusion. Check for a radial pulse and check cap refill. No radial pulses or a cap refill greater than 2 seconds means we tag them red. Move on to the next patient. If radial pulses are present and we have a good cap refill, we can move on to mental status. If they can't follow basic commands, so nod, smile, or answer questions, then we would consider them red. Otherwise, mark them as a yellow. It's important to note this system is designed for adults. For any pediatrics, use the Jumpstart system. Same premise, same colors, and they still use that RPM model. It just adjusts the parameters a little bit. You can attempt 5 rescue breaths in a patient who is apneic before tagging them as deceased. And anyone with a respiratory rate greater than 45 or less than 15 should be tagged as red. For the mental status, if they are P or U on the AVPU scale, tag them red, otherwise they're yellow. Once you've triaged the patient, take a triage tag or triage marker, depending on your system, and tag the patient. After all the patients have been triaged, rescuers will go around to the different patients and start extricating them and grouping them by triage category. Last point on triage. Patients will be reassessed and re-triaged regularly during the course of the disaster to make sure that resources are being used most efficiently.